Good afternoon, ladies and gentlemen. My name is Dr. Aurangzeb, and today we will discuss an important topic that is Minoca. Minoca is a puzzling entity, and it stands for MI with a non-obstructive coronary artery disease. And from our clinical experience and knowledge, we know that with the innovation and development of medical technology, the diagnosis, management, and prognosis of acute myocardial infarction has been significantly improved with modern technologies including ECG, cardiovascular disease intensive care, coronary angiography, reperfusion treatment, high sensitivity cardiac troponins detection playing an important role. Early studies reported that 90% of acute myocardial infarction patients have an obvious coronary artery obstruction, that is a degree of stenosis greater than 50%. And in the remaining 10% of the patients undergoing coronary angiography, the degree of stenosis is less than 50%, and these patients had non-obstructive coronary artery disease. But in today's presentation, we will focus mainly from an interventionalist perspective. We will not going into the explicit details of this vastly researched topic. So without any further delay, let's begin our presentation. Before moving further, I would like to request you to please subscribe to Cardiology Vibes on YouTube and press the bell icon so that you receive the notifications about our new videos. The learning objectives of today's presentation that we will define Minoca, working diagnosis of Minoca, how to work up these patients, what is the treatment, and long-term outcomes, and some trial data and future considerations. What we know about Minoca, that it is caused by a heterogeneous group of vascular or myocardial disorders. So basically it's a disorder that is has a heterogeneous pathophysiology involving vascular and myocardial disorders. It occurs in 5 to 15% of patients presenting with acute ST segment elevation MI or non-ST segment elevation MI, and the prognosis of such patients is impaired. So 5 to 15% of the patients landing in the cardiology ER with acute coronary syndrome are supposed to have the diagnosis of Minoca. So how is Minoca diagnosed? The diagnosis of Minoca is made during coronary angiography following acute myocardial infarction, where there is no stenosis greater than 50% in an infarct-related epicardial artery and no overt systemic etiology for the presentation. We know that plaque-related Minoca is currently managed with empirical secondary prevention strategies, and the lack of evidence for targeted and evidence-based therapies for Minoca patients is another hindrance in effectively treating these patients. So we begin our presentation with introduction, and let's not forget that Minoca is not a new entity. It was first reported over 80 years ago. And the other thing is that it's not a benign diagnosis with outcomes similar to those of patients with acute myocardial infarction and obstructive coronary disease. And the other thing that the 1 year adverse events in these patients are pretty much similar to those in patients with acute coronary syndromes. Alright, the factors associated with Minoca include female sex, which is more common in female. In younger patients less than 55 years, some genetics and physiological stressors are also associated with this diagnosis. We need an accurate diagnosis because the subsequent management of these patients requires the appropriate utilization of these entities: the intravascular imaging, the coronary function testing, the echocardiography, cardiac MRI, And the reason that because to assess the presence of infarction or myocardial disorders without coronary involvement is the key to diagnosis of this entity, and all of the mentioned investigation modalities, that is intravascular imaging, coronary function testing, echo and CMR, play an important role, and very important to reach a definitive diagnosis, because Minoca patients have impaired survival rates compared with age and sex-matched healthy individuals. In this slide, we will discuss the classification of underlying diagnosis in patients with Minoca. The underlying etiology can either be epicardial coronary artery disorder, oxygen supply demand mismatch, endothelial dysfunction, and some other causes. When we talk about epicardial coronary artery disorder, the underlying diagnosis is either atherosclerotic plaque rupture, ulceration, fissuring or erosion with non-obstructive or no coronary artery disease. So the mechanism here is basically similar to that of type 1 MI. Or it can be because of coronary artery dissection or aortic dissection with coronary extension with non-obstructive or no coronary artery disease. So the thing that differentiates this particular etiological entity from type 1 MI is the presence of non-obstructive or no coronary artery disease. In that case, this will be a type 1 MI. And whatever the underlying mechanism, that is either plaque rupture or coronary artery dissection, but when we don't find any obstructive coronary artery disease, then this will be Minoca. The other etiology, that is oxygen supply demand mismatch, can be either because of coronary artery vasospasm, coronary embolism, anemia, tachy or bradyarrhythmias, hypo or hypertension, severe aortic valve disease, or respiratory failure. Endothelial dysfunction may be caused by coronary microvascular dysfunction or spasm, and some other causes may be myocarditis with or without pericarditis, pulmonary embolism, heart failure, and other systemic conditions, for example sepsis. In this slide, we will discuss how to establish a working diagnosis of Minoca. In order to diagnose Minoca, we need to establish two things. First, the presence of clinical acute myocardial infarction and the absence of obstructive coronary artery disease. In other words, when there are symptoms of ischemia, cardiac enzyme elevation, and echocardiographic or electrocardiographic features suggestive of acute MI, this will be the presence of clinical acute MI as per the fourth universal definition of myocardial infarction. The absence of culprit obstructive coronary artery disease, that is epicardial coronary artery stenosis of greater than 50% during coronary angiography. 1/3 of the patients present with STEMI and the remaining are NSTEMI patients, and there is no apparent systemic cause for their presentation. Further investigations to establish the underlying pathophysiology for the presentation and prevent inadequate or inappropriate therapeutic strategies are also required. Minoca disorders can be classified within the fourth universal definition of MI. They may meet criteria for type 1 or type 2 MI. Now let's discuss how to make a diagnosis and how to evaluate patients with Minoca. As we discussed, once we reach the working diagnosis, we will require further invasive and adjunctive investigations in order to strengthen our diagnosis, and we can take advantage of IVUS and OCT, that is intravascular ultrasound and optical coherent tomography, in order to look for any supposedly missed obstructive coronary artery disease or dissection, in addition to establishing some of the causes of type 1 Minoca, that is plaque rupture or fissuring, etc. Coronary physiological testing can also be done, and coronary pressure wires to assess for coronary microvascular dysfunction and vasospasticity. IVUS, OCT, angiography, may so we have done intracoronary imaging, that is IVUS, OCT, and coronary angiography, and coronary dissection and plaque disruption or rupture is ruled out. We can calculate coronary flow reserve at the abnormal value less than 2, and it should be measured along with the index of microcirculatory resistance. The abnormal value are 25 or greater. We can also calculate the fractional flow reserve, but it's not valid in culprit coronary arteries and may be useful for the evaluation of non-culprit coronary artery disease. Vasospasticity can be assessed using acetylcholine testing to investigate for epicardial or microvascular spasm. And lastly, left ventriculography to look for Takotsubo syndrome. Measurement of left ventricular end-diastolic pressure can be done during left ventriculography, and the upper limit is 10 mm of mercury. Left ventricular end-diastolic pressures above 18 mm of mercury carries a poor prognosis in post-MI patients. And also wall motion assessment as determined from epicardial territorial distribution of akinesis. So all these investigational modalities can be used in order to establish or refute the diagnosis of Minoca, and sometimes most of them will be required in order to reach a definitive diagnosis. The imaging modalities discussed in the previous slide are shown here. This is a coronary angiogram. This is the right coronary artery and this is the left coronary artery, and obviously they are normal. We don't see any obvious stenosis in the right or left coronary artery. This is an OCT image, and here is a ruptured plaque. This is an IVUS image, and here we can see a dissection. In this diagram, we see the coronary vasospastic response to acetylcholine. Here, after the administration of acetylcholine, we see stenosis here and here. And finally, intracoronary physiology showing increased index of microcirculatory resistance. In addition to the imaging modalities and physiological studies discussed previously, other investigations in patients with Minoca must include a full laboratory profile including serial cardiac troponin measurement, N-terminal pro-BNP, coagulation screen and hemostasis, D-dimer, full blood count, renal function, electrolytes, glucose, C-reactive protein, infection screening if we suspect some sort of infection in these patients. All patients should undergo a transthoracic echo in order to be evaluated for regional wall motion abnormalities, for embolic sources, pericardial effusion, and typical features of Takotsubo syndrome. Even transesophageal echo may be needed in some patients to exclude ASD or PFO as embolic sources. In selected patients, CT imaging can also be performed. Cross-sectional CT for suspected COVID-19 pulmonary embolism aortic dissection, and CT angiography to confirm suspected diagnosis of aortic dissection, intramyocardial dissecting hematoma, and assessment of plaque burden. What is the role of CMR? CMR can identify inflammation, edema, and scar, and can assess myocardial function. CMR is recommended by guidelines in all patients with Minoca. Late gadolinium enhancement localizes the site of myocardial damage, and the pattern of distribution suggests the diagnosis. Here we can see the various patterns of late gadolinium enhancement, the arrows pointing towards the enhancement here and here, and here, along with their possible causes. I'm not going into the details because this is beyond the scope of this presentation, but you can look for them. This is a beautiful and simple approach of how to make a definite diagnosis of Minoca and how to exclude other causes and to establish the cause of pathophysiology of Minoca. So any patient who presents with ischemic presentation, who have symptoms of ischemia, elevated cardiac enzymes, electrocardiographic features of ischemia, echocardiographic evidence of ischemia, we can consider alternative or systemic diagnosis, for example, sepsis, type 2 MI or myocardial injury, or we can undergo invasive coronary angiography. If obstructive coronary artery disease is found, this is a type 1 MI. If not, then this is Minoca. And we can, once the working diagnosis of Minoca is established, we can review for missed angiographic diagnosis, for example, coronary dissection, and we can use IVUS or OCT, intracoronary imaging, and pressure wires, CFR and IMR assessment with acetylcholine and left ventriculography. We can take help from laboratory sampling and performing serial cardiac troponins, CRP, urea and electrolytes, FBC, that is full blood count, NT-proBNP and D dimers. So if any missed angiographic diagnosis is found, then our diagnosis will change to type 1 MI. Otherwise, we will use the help of these investigational modalities to establish the diagnosis of microvascular dysfunction or vasospasm, or if there is evidence of ischemic event, unclassified Minoca or plaque rupture as the cause of Minoca or plaque erosion as a cause of Minoca, with the help of these laboratory modalities, for example, in particular these imaging modalities, IVUS, OCT, intracoronary imaging, and pressure wire. The laboratory investigations will help us to establish any acute phase, any acute insult, alternative systemic diagnosis, for example, pulmonary embolism, Takotsubo cardiomyopathy, or myocarditis. Okay, so this is how to approach a patient with Minoca, how to reach a working diagnosis, how to exclude definite other causes, and how to reach the underlying pathophysiological mechanism of Minoca. Once the diagnosis of Minoca is confirmed, then what are the therapeutic strategies for patients with Minoca? The treatment of Minoca should be individualized because limited data from the randomized controlled trials is available on the treatment of Minoca. What we know from observational and registry data, if we talk about the secondary preventive therapies, there is a favorable long-term outcome with ACE inhibitors, ARBs, and statins, a positive trend with beta blockers, neural effect with dual antiplatelet therapy, and mineralocorticoid receptor antagonists are theoretically beneficial. Okay, Minoca at bad, you can check it yourself. The treatment of Minoca depends upon the underlying cause. So when the current recommendations for the treatment of Minoca secondary to plaque disruption or with evidence of ischemic damage on CMR is that these patients should receive dual antiplatelet therapy for 12 months followed by lifelong single antiplatelet therapy, high-dose statins and beta blockers, and ACE inhibitors, ARBs therapy. Other patients with coronary artery dissection should receive aspirin and beta blockers with additional antiplatelet agents, and ACE inhibitors and ARBs or statins can be all added to these patients. If the coronary embolism is the cause of Minoca, in established cases, treatment of the hypercoagulable state should be done antiplatelet or anticoagulation when an embolic source is identified. Patient can also be given ACE inhibitors, ARBs, and statins if needed. Minoca patients with an underlying diagnosis of epicardial or microvascular spasm should receive calcium channel blockers. Nitrates and potassium channel activators may be considered as adjuncts. ACE inhibitors, ARBs treatments after MI and statin therapy may be considered if coronary atherosclerosis is identified. Otherwise, we can only give these patients nitrates and calcium channel blockers along with aspirin. Patients with structural microvascular disease should receive anti-anginal therapy, either beta blockers, calcium channel blockers, or nitrates, ACE inhibitors, ARBs following MI, and statin. Microvascular disease is often under or untreated, and effective treatment may benefit from a stratified approach with trials for novel therapeutic options awaited. Treatment for diagnosis of supply-demand mismatch depends on the underlying cause. Additional secondary prevention may be indicated in the presence of mild or non-culprit coronary artery disease. That was all about treatment. Now, what are the outcomes of patients with Minoca? The prognosis and outcome of patients depends on the underlying diagnosis for their presentation. Mortality and the incidence of major adverse cardiac events for Minoca patients reported as comparable with those of patients with obstructive coronary artery disease. Significantly worse than for the general population. 1 in 4 patients experience a MACE within 4 years, including death, recurrent MI, hospitalization with heart failure, or ischemic stroke. And this is taken from the Sweetheart Registry. A large systematic review and meta-analysis of 1924 Minoca patients reported that all-cause mortality at 12 months was 4.7%. In the Sweetheart, mortality 2.4% at 6 months. So we see that generally Minoca carries a poor prognosis for age and sex match controls. Also risk assessment is also required because till now it's uncertain because of no clear etiology. But raised CRP, increased severity of atherosclerosis, plaque rupture, increased local or systemic inflammation, all carries a high risk for recurrent events. And assessment of prognosis in patients with Minoca is also important, and it can be done with CCTA with the assessment of pericoronary fat index and increased prevalence of higher risk non-obstructive intracoronary plaques. Let's discuss what are the effects of Minoca on the quality of daily life. Till date, no studies focused on the effects of Minoca on quality of life, including persistent ischemic symptoms and psychosocial parameters. The Carmica trial demonstrated that in patients with angina symptoms and/or signs of ischemia with no obstructive coronary artery disease, diagnostic certainty and appropriate stratification of medical therapy can improve both symptoms of ischemia and quality of life scoring. So from our presentation, we can conclude that Minoca is a heterogeneous working diagnosis that requires a multimodal approach to investigation, both during angiography and subsequently with CMR. Identification of the underlying cause is paramount, although based on observational data, approximately 2/3 of cases may be related to plaque disruption. Treatment is currently empirical and clinical trials are ongoing. Guideline-based stratified therapeutic strategies to improve mortality and MACE will require further large randomized trials. These are the take-home points. MI with non-obstructive coronary artery disease is a heterogeneous working diagnosis requiring further investigations during and after invasive angiography. Clinicians should consider the use of intracoronary imaging and coronary physiology testing during angiography to assess for plaque disruption and vasospasticity. Cardiac MRI with gadolinium contrast is recommended in all Minoca patients. Minoca is not benign and has comparable outcomes with acute MI due to obstructive coronary artery disease. Treatment of the underlying cause is paramount, although at present often empirical. There is an unmet clinical need for stratified therapy for patients with Minoca. Thank you, ladies and gentlemen. I hope you have enjoyed the presentation. If you have any questions or queries, please post them in the comment section. And also, I will again request you to please subscribe to the channel and press the bell icon. Stay tuned for our next videos. Thank you.